Good evening and welcome. Sorry, a few little hitches there, but I think we're good to go. And so welcome to everybody here, welcome to everybody online, and particular welcome to our guests this evening who have come all the way from Cornwall. So Elizabeth and Jamie, and you're here later, me talking about Wiz. Elizabeth is actually known as Wiz, so Dr. Wiz. So she's that's how she will remain. So we just a few housekeeping bits as usual. If there's a fire alarm, please out of the front door, turn left. Muster point is by the cafe. Apologies for absence. I'm afraid we've got rather a lot of apologies. So we've got Adrian Manhire, Caroline Anderson. Oh no, Caroline's actually online. I've seen her. I think Angie's online as well. Jeff Holman, Sue's here, which is great. John Rosen, Marcus Wilkinson, Amina and Ali Hussein, Professor Claire Stewart, and my brother David. So, moving on. Oh, yes. Since the last meeting, we had a fabulous meeting last time. Thank you so much, David. Thank you for stepping in at the last minute. Fabulous talk on photography, wonderful photos, lovely anecdotes, and great top technical tips. So thank you very much. Yeah, he purports to be just a mere amateur, but he's much more than that. Upcoming social events. So on the 4th of June, we have our annual quiz. Please, please, please come and join us. Either sign up on your own and we'll put you in a team, or come as a team. We really do need those numbers in soon. The cost includes a meal in the evening, as well as champagne for each of the winning team, each member of the winning team. Yeah, he's a quiz master, so so please come along to that. Oh, sorry. And then the 13th of June, there's the annual golf competition. Now, Bill Percival is organising this, and again, we need numbers, please. So, and we need those ideally by the end of the week, if possible. So please, again, do sign up. And for those non-golfers, they do a lovely afternoon tea, which actually is really good value. Having had it last year and the year before. And on the 17th of June, a group are going out to the Nottingham Open. So if you wanted to get your own tickets and join up, let everybody know you're there. Last year it was a lovely social event. Not much to report, except for last Saturday, part 2 of the willow weaving workshop. Which was absolutely fabulous. So Sharon Scriven and her daughter Lucy brought along the willow, and there we are creating our wonderful obelisks, 6 foot tall, and I think we did well. See the end results. The challenge was getting 5 people and 5 obelisks in a car to get home, but we managed it somehow.
Hello. We've already been introduced, but I'm with Mrs. Jamie.
Hi, everyone.
I'm currently a GP trainee, and Jamie is a trainee. We're going to talk to you about our last 5 years of what we've been up to, which starts us off in COVID. So 5 years ago, I was on my F3 year. I had done 6 months of ED and then was away in Nepal as an expedition doctor. COVID hit, and we both ended up in North Devon ICU. That very attractive photo. I didn't realize it was so big on the screen.
Oh yeah.
Giant. So although COVID in North Devon wasn't as bad as it would have been in Nottinghamshire and all of the big cities, we were quite a small hospital. So for us, even with a few patients, it made a massive difference. Our ICU had 8 beds, which very quickly became overrun with COVID patients. We spilled out into theatres. Theatres are split into 2 patients per theatre, so 2 vents either side. And then half of the respiratory ward became our clean ICU. And we split up into, so we were SHOs and consultants, and we split up into COVID teams. So they kindly put us together, so we saw each other. So we were a COVID team with 2 consultants. We did 2 long days, 2 nights, and then 4 days off. So we worked hard, but then we had 4 days off. So actually we had a fantastic time as well.
And no one else could come and join.
Well, that was the best bit. So actually we lived right by the beach in Saunton Sands in Croyd, and nobody could get to the car parks. So we had the whole beaches to ourselves. So we had a very weird experience of half the time working and the rest of this.
Yeah, so we'd applied to jobs in New Zealand before COVID hit. So you'll cast your memories back, it was sort of February, March. We'd applied, I got a post and an offer of employment starting in August, due to finish ACCS training. And that kind of got put on hold, but they hadn't forgotten, and neither had my bosses and Wiz's bosses. And they were lovely. They were really kind. And they basically said, you guys have stayed on, you've helped bridge the gap, please go. We'll be okay. And it was amazing. We got to take up our posts in New Zealand, and it was an utterly bizarre experience. We went off on flights fully in PPE, without the gowns, obviously. And then we turned up in New Zealand, we got put onto a bus, and essentially we had the army meet us at the hotel. They marshalled us into our rooms. We were allowed out of our rooms once every alternate day to be essentially walked around a field in a pen, whilst the army watched us from around. I'm going to touch wood. Hopefully this is the closest I ever get to being a prisoner. But essentially it was, you were allowed out for about 10 to 15 minutes a couple of times a day. The smokers seemed to get a slightly different allowance, and they could go out more frequently, but we would be allowed out sort of once or twice a day into a small concrete area at the bottom of the hotel. This was our view out of the window of our really quite nice room. And for the rest of the time, it was essentially entertain yourselves. One of the nurses who was coming around doing checks on us said that we looked and appeared to be a very healthy couple by comparison to the number of bottles lined up outside of other people's rooms, and the fact that we had our lights switched on when she came round at midday. Okay, so that was 2 weeks. And essentially, yeah, army-led, 2 weeks, utterly bizarre experience. And then we were released into Auckland and into New Zealand with no COVID.
So that was an amazing. We just walked out and suddenly life was back to normal. So we were working up. So this is the North Island. That red dot at the top is the top of the North Island, the Cape. But we were working in Whangarei, which is Whangarei. You'll read it as Whangarei. That's where we were up there. And we were very lucky to live in a place. I challenge anyone to say that. Nungaroo. So we lived in Nungaroo, Whangarei. We fell on our feet. One of the ICU consultants was going down to the South Island to do a PhD, and we were lucky enough to rent her house, which had this insane deck or deck running around the house with this 360 view over the bush, right by all the beautiful local beaches. It's so this is mainly just holiday photos, this whole talk, but they are, yeah, it was tropical up there and absolutely stunning.
So Northland, and I suppose New Zealand as well, I'll mention. So New Zealand has a population of 5.5 million, which is obviously a little bit smaller than the UK. Similar size land mass. The proportion of the population of Māori in the whole of the country is closer sort of to 25%, but up in Northland it's a far higher proportion, so you've got 45%. And in terms of the socioeconomic and demographics, you're looking at a much poorer, more widely spread rural community. And it's interesting that it's quite inhospitable in terms of trying to get from A to B is quite difficult. Hence why you'll notice that we jumped around in a helicopter coming up. But essentially, getting from, say, for instance, the far north, all the way back to Whangarei would take you approximately 5 hours at a good pace and a fair lick. driving and would take sort of 7 hours maybe to get back to Auckland. So you can imagine that if you were unlucky enough to have your cardiac event or your stroke up in the far north, then without a sort of a get around service, you might be struggling. So the other thing that I will touch on it, we had done a little bit of research about New Zealand, but I wasn't aware that there was a big gang culture out there. And then methamphetamines or meth, and we might touch on that a little bit coming up.
So what it also gave us, the far north, was a great opportunity to travel around in our van. There'll be lots of photos of him, but this is Gustav. And we went up to lots of very remote beaches and had a wonderful time.
To be clear, we didn't name him. He came pre-named.
I love it. And this is just one of the many beautiful other beaches up there. So things that we learned about the Māori population. So they speak Te Reo is the language. It used to not be a written down language, but recently they've actually started to write it down. And a lot more people are now learning it and taking courses. Lots of simple phrases make a big difference, but kia ora is hello. And we learned quite a lot of different medical terms, such as puku, tani, mimi, which is your wee. Things like that actually really made a big difference. And New Zealand is in Te Reo, it's Aotearoa, which means land of the long white cloud. We learned terms such as whānau, which is a lovely term. It kind of encompasses not just your family, but also your friends. So like your support network, I suppose we call it, but they just call everybody as your whānau. In ICU, we'd already used to family meetings, which you might get 3 or maybe 4 or 5 members at. A family meeting with the Māoris, 40, 50, maybe, which could sometimes be quite intimidating, especially if they were very large gang members with face tattoos. But that's what happened. If one of their members of family were unwell, everybody came to the hospital. They would bring sleeping bags, McDonald's, and camp in the waiting rooms until they knew what was going on. Luckily, there was usually a spokesperson, usually a more friendly looking elderly lady who you could direct what you were saying to. We learned about the iwi. So your iwi is kind of your religious area, and that's where you grew up. So lots of different iwis. Doesn't matter where you've moved, you'd always go back to your iwi as where you're from, where you're connected to the land. And they have marae, which is kind of their equivalent of a church. Karakias. So a karakia is a prayer that they will say, which often they'll say it at the beginning of a meeting. Open this meeting with a nice karakia. But it's also a nice prayer to say around somebody who's unwell as well. So often before flying somebody, if there was time, we'd gather and someone would say a karakia for the patient. These are all things we knew nothing about before, but it was really useful. Simple things such as you don't touch the head of a Māori, and you certainly don't sit on any furniture around them. And we had to swat up on the Treaty of Waitangi as well in 1840. It was the meeting of the British Crown with the chiefs of the Māori, and when they accepted British sovereignty. Still quite controversial. The writings of it, it's written in English and then it's translated into Te Reo. And the translation is quite different to what the English version says.
Yep.
And I will not say anymore. But this is the Waitangi Treaty Grounds. Actually, we're up in Northern, right at the top over there. That is a marae, top left. And this is a waka, which is the war canoes of the Māoris.
Guilt. So I don't know. I suppose some of you may or may not be British in the audience. And I don't know whether or not when you've travelled to different places in the world, various times you might potentially have things that the British have done abroad brought to your attention, and you might get some element of guilt. That, to my mind, most of the time, and I realise that I am a certain subsection of the population, that is not a daily thing that I live with, and it's not something that comes across my thought process on a day-to-day basis. guilt in New Zealand, and especially probably more so in certain areas, and Northland is one of them. It's a day-to-day thing. It's fascinating, it's nuanced, and it's not something that we were expecting. So the Māori, if you compare them and contrast them to other sort of First Nations around the world, then you've got Canada and America, where the First Nations have not done particularly well. You could make a very strong case that the Aboriginals have done possibly some of the not very well at all. And then you have New Zealand. So they were a warrior class, and they've done very well, relatively speaking, compared to lots of other First Nations in terms of representation on a national level. But there is interesting levels of guilt. So there were big land grabs by the Crown. There was a lot of it's not that long ago, so it's 1840. And there's some interesting backwards and forwards, and there's iwis and separate groups that have not accepted necessarily settlements, and therefore you find this very interesting level of guilt that still remains. You have real dichotomies. So say, for instance, type 2 diabetes, if you're Māori, then you can get a certain drug, a new funded, that goes to that subsection of the population. If you're Pākehā, white, then you are not eligible for that drug. Interesting, diverse, and also thought-provoking. So it's not something that we'd come into contact with before.
And then we said we'd touch briefly on some of the gangs. So we had no idea the gang culture in New Zealand. I think lots of New Zealanders don't know that much about it. It is quite prevalent up in the north, mainly Māori members, but not always. The main ones up where we were the mongrel mob, and they're known for their patches and their lovely face tattoos, and the beautifully named barbarian stormtroopers.
I'm going to break script here for 2 seconds. So Wiz and I arrived in Ngāpuhi. We had Gustav, and there was a local petrol station, and Wiz was on her way into the hospital, and she stopped at the local petrol station, and in her words, she was surrounded by what she thought was just some slightly off-looking football players or rugby players as a team. They were all wearing matching outfits. They all had matching red tracksuits with barbarian stormtroopers written across the back. She arrives in the hospital to tell her colleague, "Oh, I have met an interesting rugby team by the name of Barbarian Stormtroopers." No.
So, I mean, in our day-to-day life, I don't think either of us felt particularly threatened by the gangs up there. But it did make for some very interesting medicine coming into resus. A lot of shootings, a lot of knife crime, a lot of RTCs. And they had a thing where if you met another member of an alternative gang and they were wearing their patches, you had to fight them. Which was, of course, a nightmare for us if we had somebody in our ICU who was a mongrel mob member with 40 of their whānau, and someone who was a barbarian stormtrooper with 40 of their whānau. So we got very used to having security around. They also were linked to meth, which we will talk about a bit more.
Yeah, and they weren't allowed to wear their patches inside the hospital, etc. Yeah. So Whangarei Hospital, building right there. So last count, 246 beds. We were talking and discussing about funding, so that may shift in the near future, but 8 ICU beds, some very comorbid patients. So interestingly, we were seeing pathology that I'd certainly not seen anywhere near the numbers, but also some of the stuff that we were seeing was absolutely, well, to put it bluntly, slightly wild in terms of we were seeing rheumatic heart disease in the level that I've never seen it at. We were seeing incredibly poorly controlled diabetes. We were seeing very late presentations of things, so sort of massive thyroid goiters. You can well sort of imagine, say for instance, you're in a Māori family and every one of your elderly relatives, or not so elderly as the case may be, disappears off down to Whangarei Hospital and then never returns, dies in hospital. you wouldn't necessarily be particularly trusting of the white pakia predominantly doctors. You wouldn't be particularly trusting of hospital, and you certainly wouldn't want to engage with healthcare. So that's the challenges, and yeah, we'll talk about that a bit more. And then it was intimidating. It was interesting. Some of these discussions that you've had, obviously, breaking bad news, telling them that a loved one is sort of probably had a terminal event and might not make it through their hospital admission. It's okay saying that to about 5, maybe 10 people. Occasionally in the UK, you maybe get 12 people in the room. The idea of doing that to 40 or 50 people and trying to make that heartfelt and meaningful is a completely different ballgame. It's interesting. It's different.
Just jumping in there, we learned to take a very different medical history. It was, do you have a permanent residence? Do you have electricity? Do you have running water? Do you have a mobile phone? And do you pig hunt? Because a lot of people spent time up in the far north, completely off the grid, a lot of pig hunting in very stagnant water. So we saw a lot of leptospirosis there, and even some cholera as well.
So we had 2 key roles. One was the sort of ICU role, and then the other was a essentially helimed team. We were part of the flight retrieval service and also ICU transfer service. And that's what we're going to talk to you a little bit more about. And it was fascinating, really interesting.
So we worked with the Northern Rescue Helicopter Team, which is them at their base, and we've got lots of helicopter photos for you. So this is just a map more of just Northland. I've not got a pointer here, but so part of our job would be retrievals. So we go further up north to the little hospitals. So Jamie can kind of point out, we've got Dargaville down there, Kawakawa, which is the Bay of Islands.
Yep.
Rawini, and Kaitaia right at the top. And often these hospitals might have a few wooden buildings. They might have one roof-less kind of bed. And they did amazing work, but they were very, very remote. And there wasn't a huge amount they could do. We also then would either fly those patients straight to Whangarei, if that was where they needed to be stabilized. But if they needed something like PCI or neurosurgery or ECMO or something like that, we would fly on to Auckland. And then we often would also take our ICU patients from Whangarei to Auckland. These are just some photos. So that is the helipad on the roof of Whangarei Hospital. And we often loaded hot, which I will talk to you about, but that's day and night. And that's the helipad of Auckland City. Nice sky tower behind. And that's a nice photo on the, we did have some opportunity to taking some helicopter photos. And that's flying into Auckland.
Without the patient present,
Yeah,
to be clear.
I hasten to add.
So the crew was made up of 2 pilots. They always flew with 2. So there was the captain and the co-pilot. And then there was us, the ICU flight retrieval doctor, an ICP, so an intensive care paramedic, and an ICU flight nurse. And sometimes that would be a flash team that would come together, and sometimes we would have a bit more time to sort of gel and talk about stuff.
So this is our transport trolley. It does look very narrow, and it was very narrow. And the population of Northland are not narrow. But you can kind of see those wings either side that really extended it. And I don't know how we managed it, but we got most people onto it. But it only just fit in the helicopter, so everything was very, very tight. But we get a ventilator on, so they could be intubated and ventilated patients. We had a standard monitoring set. We could have up to our infusion pumps. We could have up to 5 infusion pumps on the tower. And we also had a defib in there as well, so we could do CPR, shock, and pace if necessary while in the helicopter. So the difficulties of it, the helicopter was tiny, and therefore space was at a premium, and everything was very cramped. So you had to learn your environment and work with it. We usually loaded hot. Now, I can't remember what it's called again. The
Rotor blades.
Thank you. So the rotor blades, it meant that the rotor blades were still going. So you've got your patient, you're on the roof, and you need to get them into the helicopter. The rotor blades are going. You've got your big headphones on because of the loud sound is so loud. So you can't communicate with people except for waving. You need to get a patient into the helicopter, still protecting their airway because they're tubed, and they need to go up this very precarious ramp into the helicopter while you make sure at all times you're ducking so you don't get your head chopped off. And the last bit, once you got their patient in, everybody else in, you'd look at the pilot who would give you the thumbs up, and you got the privilege of going around the front of the helicopter, one arm on the front, ducking, 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 so you could get round to your side. Once you got in, you could have your headphones on and comms, which made life a lot easier. Although sometimes it was a little bit glitchy, and sometimes it was interrupted by the pilots chatting to each other.
How rude.
Well, it was a little bit difficult when they said things such as, "Oh, did you see that?" And then nothing more. See what? There was turbulence to deal with, sometimes poor visibility, which, to be fair, affected the pilots more than us. And we were traveling around some very remote areas. So we did sometimes, if a call came in while we were out, we did a few times land on the beach or in a rugby field somewhere, if necessary. Things we tried to do to get around these problems, we always try to agree roles before the flight. Sometimes not as easy if it was in a really critical, we need to go, go, go now situation. But by where we sat, as the doctor, I was always in charge of the airway and the drugs. You had your intensive care paramedic, had the defib next to them, so they would be in charge of that. And my ICU nurse could do all the different infusions. And apart from that, it was a bit of a grab and go situation. You'd make sure you had full infusions and other ones drawn up, so full propofol syringes, for example. I had an array of emergency drugs always drawn up in my pocket, all the aero equipment, and we make sure that we'd radio into the hospital we were approaching so that they would have all the doors open. Because getting locked out on the roof when you've got a critically ill patient is not fun, I can tell you that. This is inside the helicopter. So that middle picture, there's no patient in there, and the defib is sitting on the trolley, but that gives you an idea of how cramped it is. 4 seats, and the trolley just fits in. And then, as Jamie mentioned, there'd be a leg with a patient, but there was often a leg without a patient, which sometimes meant we weren't rushing back anywhere. We had time to get sushi. So that's one of our paramedics with sushi, or we'd have our favorite peanut butter slugs on the way home while looking at the surf. Here are some photos at night. We've just got all the dashboard lit up with all the lights, and they often flew blind in ridiculous conditions.
You mean with night goggles?
And yeah, some of our infusion towers. And these are helicopter photos, which we have trillions. Yes.
Okay, I think my mic is it still working? Yeah. So there was a pre-alert for a 29-year-old. Supposedly he had been lighting a barbecue. We'll come on to that a bit more. And so we were dispatched up towards the far north. I think it was Kaitaia we were heading to, and he had they calculated on the ground sort of around 20 to 30% burns, and he also had some facial burns. There was they told us that there was some soot in his airway. So on the way up, I'd already sort of talked to the rest of the team that we were going to need to intubate and ventilate, and that we were going to need to pull him back, and we were going to go to Middlemore, which was our major burns unit. When I arrived, it was a little bit chaotic. So there's essentially a one resus bay, and the patient is understandably slightly agitated, in pain, and there was a lot going on. We set to sort of essentially getting control of the situation, gave them some ketamine in order to facilitate some pre-oxygenation, and then performed a rapid sequence induction, which essentially is, for those of you who are not anaesthetists in the room, is a way of getting a breathing tube in and controlling their ventilation in a reasonably swift manner, but the safest way we possibly can. In terms of trying to do that in a remote site, it's difficult, it takes teamwork, and it was really slick and it worked well. we then had to make some sensible decisions. So for those of you that sort of work with burns regularly, I apologise, I'm not trying to teach you to suck eggs, but the tissues are going to start to swell and they're going to get bigger. And therefore, rather than taping or tying, we had to attach the tube to the teeth with the use of a suture around that. And then we also taped over the top of it, but with the awareness that the face was probably going to start swelling. We knew that if we didn't put cling film over everything that was burnt, then actually trying to get him into that trolley that you saw earlier, everything was just going to sort of stick and be a real mess. We assessed, and both myself and the ICP agreed that escharotomies were not required at that point in time. So those are incisions that you can make on the chest wall in order to facilitate better ventilation. So we were achieving acceptable targets. And then utilizing the Parkland formula, which is essentially a way of making sure that, so there's a risk with burns patients where essentially you can either flood them with too much fluid or not give them anything. And this gives you 3 mils per kilo per body surface area that's burned, and it hopefully gives you the right amount. And you're meant to get that within the first 8 hours, half of it, and then the rest over the next 16 hours. But essentially, whilst I was in the back of the chopper, bear in mind that I'd only arrived in New Zealand about sort of 2 months earlier, and was still slightly new to various different bits and pieces, the ICP came over the comms and said, Jamie, so when you hand over this patient in Middlemore, you do know what's happened, don't you? And I said, well, I got the handover. I think I know what's going on. And they said, well, they've told you that the patient was lighting a barbecue with a match and then with barbecue lighter fluid, sprayed it on there, and then it's gone back up and exploded in his face. You can tell that story, but also just mention that there's a strong possibility that the gentleman was cooking meth at the time, which was nice to have a heads up on.
And then one interesting case from me, we had a call for a 28-year-old from Wabrawini, which is another one of the places in the far north, who was bleeding from a varicose vein, no past medical history. At which point I said, are you sure you need the helicopter? They said, yes, we need the helicopter. So on arrival, they've just got one bed resus, nothing else. I turned up to find a very, very obese 28-year-old male, meth smoking, asthmatic, who turned out to have meth-induced cardiomyopathy and terribly controlled diabetes, which he didn't know about. And he'd already lost 2 to 3 litres of blood, and we could not stop him bleeding. So we travel with blood boxes. We will travel with 3 units red blood cells, some freeze-dried plasma, and some fibrinogen concentrate. And we had to stick in a load of lines, an arterial line, central line, and basically flood this guy with as much as we could while we flew him back to Whangarei. It was very difficult to get him into the helicopter. And we were there squeezing blood. But we managed to get him to Whangarei and straight to theatre, where eventually the surgeons managed to stop the bleeding. But I think he lost 5 litres in total in the end. Went into cardiogenic shock, ended up in the ICU with a very slow respiratory wean. But it was a good outcome in the end. But it just kind of shows you, called the Wild West for a reason. You don't really know what you're flying to. Oh, this is just a joint case that we're both involved in. So I was on the night shift as the IC registrar. This is a 60-year-old farmer in the far north who likes the drink. So up there, it was quite common that he would provide services, vegetables, tractor rides, whatever, for the local population, and they would pay him by leaving alcohol in his letterbox. One day he found 2 bottles of port, left anonymously, and didn't think anything of it. Had the first one, delicious, not a problem. A week later, tried the second one. Now, he did noted that the seal on the second bottle was broken, didn't really think anything of it, had half a glass and felt violently sick. That was that evening. The next day he got himself, which was still about, I think it was a 2-hour drive and a boat ride to Kaitaia Hospital, which was the one the furthest north. saying, "I've been poisoned." Now, he had normal observations, a mild AKI, nothing else to note. So they said, "Good God, this man is psychotic." He eventually got transferred to Whangarei Hospital by ambulance just because he was confused, delirious, and because of this huge psychotic episode he was having. Admitted into the wards under medicine, under psych. Now, I got a referral at the beginning of my shift about him saying this guy's got a mild acidosis, metabolic acidosis, but don't be too worried about him. I'm just letting you know. And that is Kaitai Hospital, just a picture from when flying in. This guy deteriorated rapidly. He developed type 2 respiratory failure, acute renal failure, multi-organ failure. I did a bit of a snatch and grab. I got one of my ICU nurses. We literally grabbed him from the ward ourselves, wheeled him ourselves to our ICU, did an RSI, intubated him, ventilated him, stuck in lines of ASCAF, he needed dialysis, and he was very tricky to ventilate, and his gases were completely off. And the last thing he said to me before we intubated him was, "I've been poisoned. The port is in my bag." So we discussed with Auckland City and they accepted him for ECMO, at which point my night shift was over. I was very pleased about it, and Jamie appeared.
To be clear, this photo is on another flight, or maybe on the way home from. Not during this flight, because he was really quite unwell. So we were struggling. We had him on multiple vasopressors. He was cardiovascularly all over the show. You can't dialyse in transit, so you have to stop dialysis and then transfer. It was essentially worked out that it would be quicker based on helicopters and transfer times for us to scoop and go from our intensive care than for them to come and put him on ECMO. He unfortunately was put onto ECMO. We went straight to theatres, but he died 5 days later.
So the police tested the bottle of port in his bag, and it was positive for the herbicide paraquat.
Yeah, so paraquat's not something that I think most of us regularly use in our garden. Essentially, it does have rapid absorption. It's not metabolized, and it's very toxic. So essentially, if you don't get it treated within a very short, rapid period of time, you've kind of got no chance, which is, so 4 hours within ingestion, you're meant to attempt hemodialysis and start treating. And he clearly had that point in time where he'd sort of recognised he was unwell, presented to a peripheral hospital, and then had 24 hours before Wiz picked him up on the wards. So we did try, I don't think, we certainly didn't know what was going on at the time, but we did try an acetylcysteine and did get some steroids. But no, it sadly wasn't going to work.
And this is an ongoing murder investigation in New Zealand. So I check the news reports now and again, and every year there's another story, and they're still trying to work out what happened. I'm hoping one day they catch the culprit. But yes.
Any budding organic chemists in the room?
It's a quiz.
So we've mentioned it already tonight. Yeah. So it's methamphetamine. So a little bit of history for those of you that like drugs and history. So amphetamines were first synthesized in about the sort of 1920s. Initially used for nasal congestion, asthma, narcolepsy. There's some other stuff that it wasn't really used much for, but myasthenia gravis and sort of persistent hiccups is an interesting one. And then the patent came along and people thought, okay, well, how can we get around this? Well, we'll add a methyl group to it. And essentially applied to the same indications as amphetamines, but, and here's the side bit, which is it was very addictive, incredibly so. And therefore manufacturing stopped. But, as with lots of things in life, it led a different life and it found a different path, and it made its way to the black market, and it's essentially an epidemic. So behind opioids, which aren't really a thing in New Zealand. So you have them in hospital, you have opioids, but you don't have opioid addiction. It's certainly they don't have a route in. They don't find their way there, and it's also not sort of made in New Zealand. Whereas meth, as we're going to come on to talk about, is quite easy to make. Next slide, please. So yeah, what are they cooking up north? Essentially, meth can be, probably some of you have watched Breaking Bad, but essentially you can, with rudimentary equipment, cook it in your sort of kitchen or your sort of outhouse. Interestingly, in New Zealand, whenever you sign a lease or whenever you get a mortgage, you have to sign an agreement to say that you will not be cooking meth, which I thought was hilarious, but sort of it is a real problem. Gangs are very much involved, so there's a large amount of sort of it being driven by gangs. It's easy to get hold of, there's lots of it, and it's really addictive, and it's not a nice drug, and we're going to talk a little bit more about it. So this was the bit that I found really upsetting. So kids and people of a certain sort of like late teens, early 20s, they would get them hooked. It's very addictive. You get the same amazing dopamine surge that you get when you get a gambling win. They get that same dopamine hit off it. And then on top of that, not only were they very clever at sort of making it reasonably priced to begin with and then ramping it up once you got hooked, but they would all then, once someone fell on tough times, I was told that by some of the drugs workers out there that essentially what they'd do is they'd start giving people freebies if they were struggling to make the sort of their payments, just to tide them over, to keep them as a customer, so that then they had an opportunity to find more money, which normally was where the sort of criminal element of it came in. So they would then have to start finding ways and means to acquire the drug to make payments. So it is quite sad. Pathophysiology. So MA at the top stands for methamphetamine, and for those of you that are vaguely interested, and I include myself in this, I quite like this slide. So it decreases the action of monoamine oxidase, which essentially breaks down dopamine. It also stops dopamine being reabsorbed, and it encourages reverse transport of monoamine oxidases, and this happens both centrally, so in the central nervous system, but also some peripherally as well. You get the euphoria, the hypertension, the vasospasm. You can get strokes associated with it, aortic dissection. You get increased inflammation, fibrosis, remodeling. You can either get direct or sort of just long-standing arrhythmias. It causes atherosclerosis, and you can get MIs and pulmonary hypertension associated with it. So this is a very busy slide. It's the busiest we have. But all to say, essentially, when you had someone coming in who was in their 30s or 40s, short of breath, with chest pain, this was often the culprit. So you would get a presentation of someone in flash pulmonary edema, massive heart failure, and they would be in their 30s and 40s. And it wasn't due to congenital heart abnormalities. You would have to think, okay, well, we're doing an ECG, we're going to do a trop. That often wasn't raised, but sometimes it would be, especially if it was co-taken with cocaine, so both causing vasospasm and leading to MIs. BMP was massively raised, and that was really interesting to look at. And then quite often what we would do is we would place an echocardiogram, sort of a probe on the chest, do an echo, and then you'd see massively dilated left ventricle. And I mean big, it was huge. It was quite scary how frequently this would happen. So it would happen sort of maybe once a week, once every other week. You'd see someone who was in their 30s and 40s with just big hearts. Next slide, please. So, do anesthetics. I have a physics interest. So all of you will remember Laplace's law, obviously, from GCSE. T is the surface tension, P stands for pressure, R stands for radius, 2 times the thickness. So once again, not trying to teach you to suck eggs, but dilated cardiomyopathy is related to the fact that as you increase the size of your radius, your surface wall tension will increase, as will your pressure. And it's a vicious cycle. You spiral, and essentially you get massive increases in your sort of tension and your surface wall tension due to ongoing changes, and it just continues to get worse and worse. Although, that being said, weirdly, amphetamine abstinence would allow the heart to improve slightly, but you do get all these changes. So you get inflammation, dilated cardiomyopathy, MI, and electrical me remodeling. Next slide, please. So I don't want you to read all the blurb, but essentially these are sort of taken from a paper, but this is what we were seeing. Sort of people in there anywhere from the age of sort of 18 up to about sort of 40s, and they would have big dilated left ventricles. It was interesting, it was fascinating, and I've never seen anything like it in terms of you would be doing it and you would think, oh my goodness, this person has like a congenital heart disease, and they really don't. They just had taken a large amount of meth. Next slide, please. So treatment, so MACM stands for methamphetamine associated cardiomyopathy. And essentially they were hypoxic quite often. We would sometimes have to intubate and ventilate. You might have to treat the excessive tachycardia, and benzodiazepines works well for that. Occasionally beta block them, but also be aware of the fact that they might go into cardiogenic shock and you might need inotropes or vasopressors. We were aware that you could potentially send them into fluid overload. Rhabdomyolysis, so you would do a CK, but you'd also want to know sort of where they were heading with their hypothermia. There was a dearth of ice packs, and that certainly got utilised on a regular basis. And then coronary or peripheral vasospasm, so you might potentially need to be thinking about that as well. Didn't get so much involved in the chronic management, but I did meet some of the drug and alcohol workers, as I mentioned. And abstinence, there was big sort of community-wide projects in trying to stop meth, get their kids out of getting involved with it. And the real sort of, in schools, there was the message of, this is bad, this is what it causes, and this is what we need to do to stop it. Sort of the end game, essentially, yes, you would need anticoagulation. You gave general heart failure therapy, and some of them, if they'd been abstinent for long enough, they were eligible for heart transplants, and you would see patients who had had heart transplants for meth-related cardiomyopathy.
Right, so some more physics. I'm kidding. I'm just going to give you some life relief. So in between, once we finished our helicopter job and ICU in Whangarei, we managed to get 2 months in order to travel around the South Island in Gustav, of which we had an absolutely fantastic time. Stayed on multiple beaches, did some amazing hiking in the South Island. That's Roy's Peak down in Wanaka. Yeah, we had just a fantastic time traveling around. That is at the bottom of the South Island. And we very much did not want to go back to work. Drank a lot of wine as well at the vineyards. It was wonderful. This is the Kea. So there's lots of brilliant birds in New Zealand that we love. This is a mountain parrot. Sounds like a screeching cat from the air. And they have wonderful red wingspans when they open their wings. And they are very cheeky and very clever. So they've done lots of studies on them, and they have the age of a 5-year-old, their brain. And they've worked out there's a tunnel in New Zealand that goes through a mountain. And instead of having to fly up and over the mountain, they've worked out that if they just wait on the queuing cars and sit on top of the roof bars, they can ride the cars all the way through. This is, wait, did I miss? Yeah, so we stayed in lots of dock huts too. So dock is Department of Conservation. They have these fantastic huts all around New Zealand that you can hike to for one-day hike, or you can join them up to do multi-day hikes. You book in and you've basically got a very rudimentary, but a big bunk room where you bring your roll mats and your sleeping bags and you all lie side by side like sardines. bring your stuff to cook your food, and you have a fantastic time. And we enjoyed them to be up above the clouds, some skiing ones as well where we helicoptered in. And this one is near Mount Cook, which is the next slide, which is Mount Cook in the background, known as Araki in Te Reo. And more photos, because why not? And beach photos.
So we then, for the reason for me anyway, we'd done a year of intensive care, and I then found myself in a position where I'd done ACCS, and then there was a curriculum change back home whilst we were away, and they basically changed it so that they decided that you needed one more year, and rather than being able to apply to ST3 posts, you'd have to apply to an ST4 post. We had a discussion, and we basically said to each other, well, we only meant to come for a year, but we're here, and why don't we stay and get this extra year that you need? And Wiz had been doing some anaesthetics and wanted to do some formal training in it. And so we both applied to anaesthetics training in Auckland. It was kind of amazing in terms of when we both got jobs, and then they phoned up and they did something that wouldn't happen in the UK. So they phoned up Wiz and they said, right, so you're based in Auckland next year, and Jamie's meant to be based in Whangarei. We understand that you two are a couple. Would you like to be in the same place? Could we move you? Would it be okay if we moved Jamie to Auckland so that you're both in the same location? Which it is nuts. It actually showed that they cared, they were interested, and they they value their trainees, which was really nice actually. So we trained in 3 different hospitals in Auckland. Some of you will know them. So Middlemore is their major bones unit and their major trauma centre. Auckland City, they have their national women's, but they also have cardiothoracics, neuro. Their Starship, which is their paediatric centre, is sort of internationally renowned. And they also had North Shore, which I spent a bit of time at as well, and that's really well known for its upper GI surgery and for its regional work.
And I just thought I'd talk about some of the benefits of to doctors for when you train in New Zealand. So you do get paid more than in the UK, not quite the Australian money, but you do get paid significantly more. And you get meals included as well, which was fantastic. It meant that if you were working a long day, you'd have 3 meals. And it meant that actually it was part of the culture there. Everybody had lunch because it was what you did. So everybody ate, and it was brilliant. Not albeit in anaesthetics, but lots of other areas of the hospital had relief doctors. So that would be, you'd have a full rota of, let's say, medical doctors, and they tack on 5 extra doctors onto the rota to cover sickness and to cover leave, which meant that they had this fantastic culture again, where if you were unwell, they wanted you to stay at home rather than coming in. And it made a lot of sense. You didn't get people covered in viruses, coughing everywhere coming in, and gaps were easily covered. It also meant you could take leave often whenever you wanted it, which is a huge thing. It meant that also you didn't have to swap out of any on-call shifts and work them at another time, which again made life a lot easier. They reimburse you for a lot of your fees as well. So your MCNZ, which is the equivalent to the GMC, your medical indemnity, your college membership, so for us that was ANSCA, and courses and conferences, and everything was funded. And if you joined a union out there as well, the one we joined gave us $2,000 a year or every other year. For things like laptops, phones, stethoscopes, etc., etc. And all those things combined did make you feel a lot more valued.
Yeah, so talking about this is interesting. It's sort of like it's not that long ago, but it feels like a long time ago. We were talking backwards and forwards, and essentially we were having a great time. We were really enjoying ourselves, and we definitely turned up with an attitude of we were going to give it our best shot. But we also very much always felt very much that we were British, that we were really close to our friends, really close to our family, and that coming back to the UK was something that we were almost definitely going to do. And then we decided to press the button essentially.
I promise we're always coming home.
Yeah. But essentially, it didn't look easy, the navigation path. You can envisage essentially we were living in the same place, we were both working in the same place. That was guaranteed for the rest of our training. And what we were giving up was essentially that. And then we were going to
Quicker training program.
yeah, and then we were going to try and navigate our way back to the UK, where it wasn't guaranteed that we would be in the same place. There was no way of linking our applications, and one of us could have ended up in Scotland, and one of us could have ended up down on the south coast. So there was a bit of risk involved. All of my stuff that I've been doing in New Zealand, I've been logging with the anaesthetic college in New Zealand and Australasia, and therefore I had to transcribe all of that. There was a process and it worked quite well, but it was quite time consuming. Essentially 2 years of my anaesthetics was converted to 1 year, and therefore I got my top up here. I applied, had an interview, and then there was the process of getting our licenses back in the UK. There was a bit of an uncertainty. So there is, I don't know how much you guys know about sort of training and numbers, etc., but it hit the headlines last couple of years that there were over 800 anaesthetic trainees who didn't get posts not so long ago. So from my part, I knew that I had a reasonable CV. I had a reasonable number of years under my belt, but actually it was slightly daunting coming back.
And then for me, so I decided to change from anaesthetics training to GP training. So to get back, I had to fill out a CREST form. So that was because my foundation training done in the UK, so F1, F2, was 5-6 years ago. Apparently it no longer counted. I might have been a trainee, anaesthetic trainee in New Zealand, but no, we still would like confirmation that you can work at the level of an F2 doctor. So I had to go around with this CREST form and get consultants to sign off that I could do catheters and I could understand and assess a patient and look at an ABG, which took so long and it was so frustrating. And it's the form that the international graduates, medical students. I did the GP exam, the MSRA, which was fine. There is no interview process for GP training or a CV review, which I will touch on in my next slide. We had to reapply for our licenses, which took a long time. The paperwork and the admin took us weeks to get back in. I tried to apply to get some of my time counted. So in GP, they now offer, you can get up to 6 months of prior work counted if you do a very, very lengthy process, which I did do, and I have had 6 months counted, and I will come to that in a minute. And then again, with everything, it was a bit of a lottery where we ended up. What I would say is it sounds like in the press that we're always so worried about all our junior doctors going abroad. And I think it's a fantastic thing for everyone to go abroad. I think it gives you wonderful experience. Instead of trying to stop people going abroad, I think they should trying to make it more appealing and easier to come back. That is what I would say. It was not easy, and our colleagues in New Zealand could not understand what we were doing and why. But we had success. So I found out whilst on the W track hiking in Patagonia that I got Cornwall for GP. And Jamie found out underneath the lovely mountain of Amadablin on the Everest Base Camp trek that he had got Cornwall for anaesthetics registrar training.
So, yeah, back in the NHS, we're really happy to be back, and I'll lead with that because actually it's been great. It's been interesting, and I've seen stuff since coming back that I thought, hang on a minute, this isn't real. So I turn up and say, for instance, try and find the patient and pre-assess them for an anaesthetic, and they're not in one of the normal beds on either side of the ward, but they're in a middle bed that's now a new permanent bed of the 2 beds in the middle of a ward that is sort of now got A and B status, as well as the extra numbers around the outside. But it's that kind of thing. It's the fact that actually, as the anaesthetic trainee at night, you'll walk through ED and there are literally people lined up on the side. And we've touched on this earlier, but New Zealand hadn't had that. It's got its own pressures, but it wasn't quite as much under the pump. Whereas I've been lucky. I've gone back into anaesthetics, and I think anaesthetics is reasonably well looked after. You've gone back in.
My first year has been in kind of the general hospital, so you go back into the trials and tribulations that come with that. So you get your rota potentially 24 hours before you start, and then only for the first 3 weeks. So heaven forbid you might have a friend's wedding to go to or any plan. Most of the roles I've worked in so far haven't had a rota coordinator, so there's been constant gaps in the rota. And it has been an absolute mission to try and get annual leave. And to get any leave, you need to collect up all your on-calls for that leave and work them in the bit before. So by the time you get to the annual leave, you are absolutely exhausted. And then there is also this culture of, I've seen so many people come in over the winter who should not have been in hospital. Not everywhere, coughing everything, but there's gaps in the rota already. And if the culture is come in. If you're unwell, come in. And having seen the alternative, it's strange seeing it this way.
Yeah, it is nice to be back, though.
I think the one thing we would say, in New Zealand, you work for Te Whatu Ora, which was the general health system out there. But actually, you always felt like you worked for just the hospital you were in at the time. So it is nice to be part of the NHS. I was just going to briefly touch on just a few things I found in GP training. I think that in your first year nowadays you do 1 year in hospital and then 2 years in GP land. You can have wildly different experiences in your first year. So I was quite lucky and I got my top choices of jobs for my first year. So I managed to have obs and gynae and peds, very useful. And then you have to do a gen med job. But there are some people that have been sitting in histopathology clinics or community psych. And these are doctors that potentially have never done peds before or ED or anything. And I don't understand, we are service provision, very much so, but I don't understand why in the GP training there can't be a rotation system where we go through all the key specialties that you need for GP. You get people who have only done their F1, F2 year and go straight in. So for the GP training, you do the MSRA exam, which is the same exam most specialties do nowadays. All the other specialties interview, every single one except the GP. Why? It makes you feel very undervalued. It makes GP seem as the option for everybody else. So what is happening is that everybody's doing the exam anyway, so they sling their application into GP, little backup. So if you don't, let's say you don't get into surgical training, but you get your GP job, you take your GP job because you're going to be in hospital for the next year anyway, while you reapply for surgical training. And it looks better because you're already in a training job. And that's what's happening. So you're getting a huge dropout rate after the first year of GP training. So it looks like an easier option, and it is a lot of people's backups. And also you get doctors who, so you could, I think if you interviewed and looked at CVs, you might get the doctors who have more experience, the ones who've gone abroad or they've done other things first. But because it's all on paper and it's all on an examination, you get the doctors who are closest potentially to med school or who have spotted up, who have only done F1, F2, have limited experience. I'll briefly touch on IMGs, who are international medical graduates. They are very important. We need them 100% in the hospitals. What I would say, this is just my experience in my trust, but sometimes the people that look good on paper with a good exam score might not be, when they work in the NHS, the people that maybe have the clinical skills or the clinical judgment to do the job. And there have been lots of us that have been doubled up with international graduates because they are not deemed safe to hold a bleep and do on-calls on their own, which just means more for all of us to do. It is an issue. I also applied for the new bit to have some time counted. I had 6 months, so I had 6 years of hospital medicine counted as 6 months. And I asked for it to be taken, my time to be taken off my hospital block rather than my GP block, because I wanted my GP time. And I was told, no, you are service provision, and we will take it off your GP time instead. It is what it is.
I end up getting really frustrated for Wiz on her behalf, because essentially, if you're honest about it, the number of times that you've been treated as cannon fodder or service provision in the last year, a certain consultant once told you that you didn't need to come to clinic because you were just a GP trainee and you weren't going to see paediatric patients.
Wildly different being a GP trainee to being an anaesthetics trainee.
And you've, like, multiple times you've said what would make sense, as if, say, for instance, for 12 months, you just literally went from peds to O&G to dermatology to then on, and you got, like, everyone got the same experience, rather than one of your friends who's going to come out with really great knowledge of histopathology, which I'm sure will stand them in great stead.
But anyway, that's my little moan while I'm here and I have your ears. And then just to finish off on a more light-hearted note, on the way back from New Zealand, we did manage to squeeze in 6 months traveling. So we did South America, we started in Patagonia, did lots of amazing hiking, and worked our way all the way up to Colombia. And then we did the classic hop from Colombia to Kathmandu for some hiking. It was the hiking season, that was why. So we did the Everest Base Camp trek, which was incredible. And that's Everest, the dark mountain just behind us. And we're on the top of Kalabatar at 5,545 meters. And then we did another trek, of which somebody else might feature in there that you recognize, where my mother and one of my brothers joined us, and we did the Annapurna circuit as well, which was fantastic. And then we finished off, as you do, we had 6 weeks in India at 50 degrees heat, which was bonkers, and then a nice surfing trip in Mexico. I understand that makes no sense as a trip. We had to pop home in between India and Mexico for a wedding. But yes. Any questions?
When graduates also
The same exam, yes.
exactly the same exam.
Yeah.
I believe that.
Yeah.
And
Yep.
so we're not being trained and paid for by the UK tax.
Yes.
I mean, I am aware of obviously that.
But it is the easiest way is
to not training for doctors within.
could not agree more with that. Yes, it is seen as I have some friends who are from Nigeria who've come over, and it is the easy way in. Even if they want to jump to a different specialty, it's get on to GP training that way to do it.
It is interesting. Like you can.
It's different in New Zealand, though.
Yeah, in New Zealand we lost points. So there were 10 points up for grabs if you were out of 100. If you were from New Zealand, you got those 10 points, and if you weren't from New Zealand, then you couldn't get those 10 points.
You weren't allowed to apply for training in New Zealand until you'd worked there for at least a year. So I think lots of other countries do have a culture of preferentially picking their doctors that they've trained first. Yeah. Yeah.
So I think it is definitely being looked at.
Yeah, exactly.
So I think there's no.
No. Yeah,
There's going to be 1,000.
yes.
You
And
said that how many in training?
well, let's say they churn out 25 in Cornwall every year, and there's not 25 GPs retiring in Cornwall every year, so I don't know where people go. Most of them GPs at the moment, my age, when they qualify, are working in EDs or urgent treatment centres, just kind of grabbing locum jobs where they can because there's no set roles for them.
I was actually going to ask a question about diversity amongst the medical workforce, but I should admit before I do, as postgraduate dean, I'm partly responsible for some of the issues you've been raising. I can reassure you that GP training's changing dramatically, so it will be 3 years entirely in general practice, actually, which is going to be a big improvement. And yes, West Streeting is looking at, because we're bound by immigration laws at the moment, and that's the problem. But the question I was going to ask, you have a very obviously high Maori population in New Zealand. Is that reflected in the medical workforce?
No.
So they have, or they had until the late sort of elections earlier this year, they had something called the Māori Health Board. And essentially that was set up, and the idea was that if you got more Māoris treating Māoris, then you'd have increased trust and you'd have increased buy-in, and then essentially on the ground floor sort of there would be a lot more buy-in, and then you would get more people sort of engaging with healthcare. It was working, it was going really well. They've kind of pulled the carpet out of from the rug, and they've just basically said, no, we're gonna remove the Māori Health Board. So that they've disbanded that. In answer to your question, there are some really great Māori doctors. There are some amazing Māori medical students, but in terms of numbers, you're looking at sort of a ratio of nowhere near 1 to 20, as in sort of it was rare rather than there was far more nurses who are Māori background, and there are far more midwives. The other interesting thing, I suppose, is to say that, and this is something I haven't really touched on, is in New Zealand, it was interesting. You didn't necessarily know by looking at someone whether or not they sort of would deem themselves as Māori. So you would have people who had, say, for instance, one grandparent who had been Māori, and therefore they, relatively speaking, to you or I, would look like they were Pākehā, but they would identify as Māori, and there was a real strong pride in their Māori background, and therefore they might potentially identify and tick the box as Māori. So maybe I can't give you an accurate answer to that.
Rather than a question. So I worked in Australia in the early 90s for a year, and your experiences of the Maori are very, very similar to my experiences of the Aboriginal community then, so it's actually quite depressing. So yeah, we saw rheumatic fever, never saw rheumatic fever in the UK. We for the Aborigines it was alcohol rather than meth, but all the same problems, and it's 30 years later and it's still happening, and even then Maoris were considered better off than Aborigines.
Yeah, I think they are still a lot more successful, but yeah, it's bad.
Good.
Thank you. In your experience, I know that you weren't doing much paediatrics, I think you said, but how is it in New Zealand for child and mother mortality, maternal mortality, and childhood anomalies and things like this, congenital anomalies, in the sort of Wild West, as you put it, where you were? It sounds as if that might be a problem.
Yeah, it was interesting. Essentially, in terms of access to healthcare and access to essentially what you would say first world healthcare, there was the provision for it. So say, for instance, if you were a mother giving birth, then you could give birth in hospital. That was free, and that was available. You could essentially access better quality care, probably, you could argue, and you would have to have come all the way down from the far north to get to Whangarei, but it was just as good a care. I worked in sort of obstetric anaesthesia in that department, and it was just as good as Cornwall is, say, for instance. But on the flip side, there are individuals who are deciding not to give birth within that setting, and therefore, I don't know, to give you a really interesting answer is the fact that when I did my medical elective, I did it in Sri Lanka. And they were really proud of their maternal mortality stats. And they had better maternal mortality outcomes than the United States. And everywhere I went, they would ask and they would say, why on earth do people and mothers in the UK not give birth in hospital? Why would they home birth? It just doesn't make sense to us. And you would get the exact same problem, which was you would have multi-Paris ladies who had given birth 5 or 6 times before, say, for instance, and they'd all been fine, and then their 7th one or sort of 5th one, they would give birth, and they would give birth up on the far coast, and then they would have a massive PPH, and they would have to be retrieved by us, or we would go out and have to help out. And it happened. In terms of numbers, I don't have numbers for you, but relatively speaking, from a maternal mortality health picture, they have really good services. It's just whether or not they decide to engage and use them. And then from paediatrics, interestingly, there's a reduced uptake in vaccines. So say, for instance, there was a real increase, and I saw far more epiglottitis out there and had to do far more awake fiber optics for that pathology because of the lack of the uptake of the Hib vaccine. I mean, that's chucked in amongst the fact that they were being so mandatory vaccinations. We had a card that showed that we'd had our COVID vaccine. We could bore you for hours on the topic of our trip out to New Zealand. We just thought we'd show you a bit of the fun stuff. But essentially, you couldn't go to a restaurant, you couldn't get served at a restaurant unless you showed your passport that showed you had 2 vaccines on your passport. But the flip side of that is that it had a huge backlash. So there were people who were really strident anti-vaxxers, and they then gave up all vaccinations. And we were just, as we were leaving, starting to see the sort of whooping cough spike. All of that stuff was coming into play. Sorry, long answer to your question.
And was there resentment about the differential access to diabetes drugs that you mentioned?
Yes, there was. I suppose in any system where you've got guilt and then you've got the packy hair, the white people deciding that, okay, let's try and do something in the other way and let's give preferential services like diabetes drugs to the Māori, you then get a backlash the other way and you end up with stalwart white Kiwis going, I'm very anti-Māori, I don't care about this, this isn't right, this is my land too. And then you kind of get more and more separation. So I think the diabetes drugs, as a good example, actually caused more of a rift between the two areas. And where we were starting to see that as we left, with the very right-wing white, I'm a white Kiwi, this is my land, government getting in as we left.
Yeah, I mean, that's essentially what's happened, is a reasonably right-wing government has come in and got rid of, they were going to be leading the world banning cigarettes and the sale of cigarettes. And then he's come in and essentially said, I need some money for my various different tax cuts that I'm giving my friends. Cigarettes earn me a large amount of tax dollars, and therefore I'm going to not get rid of that. So that was really unpopular. They did a 360 on that, and it's quite, 180.
Scrap the Māori Health Board as well.
Yeah, right.
Very sad. And they're trying to scrap using Te Reo names with the Pākehā names. Well, they're trying. Lots of people still use them. But
yeah, they have in lots of them. It's really emotive. It's really sad. I think it's really.
There's a lot of progress. Maybe too far in some things, but it's gone quite a few steps back.
And was this a factor at all in you returning, or why did you come back if it's not like this?
We came back. We came back for family and friends. And because although we love New Zealand and life was fantastic out there, it never felt like home, is the honest answer.
Yeah, I don't know whether or not how many members of the audience have ever done this, but if you take yourself and you are a person who has lived somewhere for a sort of set number of years, and then you transplant yourself somewhere else, especially even though they're speaking the same language and to all intents and purposes it looks very similar, it is very different, it feels very different, and there's it's hard to get a sense of belonging somewhere. I suppose, yes, family, very high up on the list. Friends, very high up on the list. And then I think sometimes the grass is always greener, maybe. And it's not perfect. There were some amazing photos up there and we had an absolute blast, but actually the UK is pretty great as well. I think both of us would say this, is that if you're lucky, you make some really great friends, you have a really great time, you have a really great experience. But if you're out in New Zealand and you're there for, we were there for sort of over 3 years, you do start to, there's this weird tipping point where essentially if you don't start to head and come home, then actually you're right. Essentially, if you get to 5 years, then you start to stay potentially, and it becomes, it's harder to come back. And so we made the decision that we were coming. I mean, I think we were always coming back, but it was an amazing experience, and it was great work, really interesting clinically, but also really fun outside of work as well. Does that kind of answer your question?
Now I know that poor old Professor Dane Helen Unpard herself in
Envy her that job.
We were discussing this earlier, so I've forgotten your name. Jenny. I was chatting with Jenny earlier beforehand, and essentially, hopefully this isn't sort of saying anything that's too controversial, but essentially New Zealand is absolutely amazing, but everything feels every once in a while like it's 10 years behind the UK. So there's an amazing article that was written that basically highlighted the fact that Margaret Thatcher made her cuts and sold off all our social housing, and then 10 years later the New Zealanders watched that and went, that's a really great idea, let's achieve that. And so they're kind of doing the same thing with their health system at the moment. It's a bit worrying, but I think there's lots of pressures coming, and therefore hopefully they'll find the path that works. But certainly a few of them, as we were leaving, were kind of going, oh my goodness, this is really busy. I remember just going, it's going to get worse.
Thank you very much indeed.